Normal occlusion is angle defined by line of occlusion and molar relationship. Different malocclusions classifications were given. You understand why? Because one classification cannot comprehend the entire features of a malocclusion. So they give multiple. The one which we use is angles for molar relationship and canine relationship. We have a canine classification of malocclusion, and we combine these two to report our dental malocclusion. For skeletal malocclusion, you have to again have a different spit out of information. That means when we are reporting malocclusion, during the diagnosis, we have to say whether the patient is skeletal class 1, skeletal class 2 or a skeletal class 3, along with angles class 1, angles class 2, angles class 3, and one or two of the most important feature. We'll cover that one. So once that is done, two more important things which we have to understand is our current or our previous thinking that only molar class 1 relationship is acceptable. We have now evolved over that and understood that we have to achieve static goals. Remember the static goals, Andrews? Let us repeat the 6 keys of Andrews. You don't have to memorize. Remember, you don't have to memorize. What are we looking at? We are looking at molar relationship, which is good. I am not spitting it out in terms of Andrews. I am just telling you in layman's terms so that you are able to recognize them or you are able to recall them very easily. So molar relationship has to be good. You know what is good. Class 1 or a functional class 2 or a class 3 finishing is acceptable. Yes? Then you should have a good angulation of teeth mesiodistally and labiolingually. So if we have to tell them in a terminology which is technical, we will say the tip and torque. All the teeth has slight mesial tip. That means they are not upright like this. Slightly like this. Why are we learning these keys? So that we can finish our cases very nicely. This is your finishing goals. So if you understand what is a very good malocclusion looks like, you can plan your case for that. Yes? So during the end phase of the treatment, you will be targeting to achieve this. So all your teeth is slightly mesial, and all your teeth are slightly negative torque except for upper anteriors. Upper anteriors are the ones who have slightly positive torque. Rest all the teeth have slight negative torque. As you go posteriorly, the negative torque keeps increasing. So far clear? Apart from that, what are you looking for? That your arches are well aligned. You shouldn't have any spacing or you shouldn't have any crowding. So this spacing and crowding, they talk in different terms. They talk in terms of posterior rotations or anterior tight contacts are not available. So key 5 and key 4 are actually nothing but well aligned arches without any spacing. So far clear? Key 6 is T. As we discussed that in nature, our arches have a slight curvature because our jaw, TMJ, upper jaw, lower jaw, they have to occlude. So there has to be a certain, if it is all flat, not every time you will get the maximum efficiency. So different people based on their facial structure have different curvature in their arches. Some have flat, some have 0.5 curvature. So this natural curvature we call it as curve of speed. As a target for us, we will target to achieve either flat because we want to overcorrect or until 1.5 is acceptable. That means if the curve of speed is too much high, you may have deep bite. If it is reverse, you may have an overbite situation. So get a good bite, balance and improvement, you need a curve of speed which is around 0 to 1.5. So far clear? So Andrews keys are clear. Along with that, we have understood that functional occlusion is acceptable, which means a functional class 2 and a class 3 finish is acceptable as long as you manage to get all the other features achieved. What are those other features? Canine class 1, good overjet and good overbite. Why did we say that? Because when we check the mutually protected occlusion, we realize that canine guidance and incisal guidance play a role. To achieve a good incisal guidance, you should have an overjet and an overbite which is in a normal range. And to achieve a good canine relationship or canine guidance, you require a class 1 canine relationship. So So these are non-negotiable. Canine class 1 and good overjet, good override. So the molar relationship is usually replaced by a canine plus overjet override. If you have these concepts cleared out from yesterday, we are good to go. You don't need to know. Other than that, if you forget everything else, it's okay. So far, so good since yesterday. Now coming on to the growth concepts. Growth concepts, compensation, I will just take compensation. You understand what is compensation, right? The nature tries to mask the severity. So you don't have to mug up what is the compensation of class 3, what is the compensation of class 2. All you have to do in your mind is imagine what a severe class 3 looks like. Then think as an orthodontist to reduce that, what you would do. And if same direction but nature has done the job, it is compensated. If it is not done, it is not compensated. That means, for an example, if a class 3 is supposed to be, what do you imagine as a class 3? Reverse over this severe. Okay? So to reduce that, what will you do? You will proclaim the upper and retroclaim the lower. So you will reduce this severity. If you see that in the patient, that means it's a compensated class 3. If you don't see that, that means it's a non-compensated. So far clear? There was a confusion yesterday. When do you compensate and when do you decompensate? So if you are, for all of you, you will not be doing surgical cases, right? That means you will, in most of the cases or almost all the cases you do, if you have a compensation which is already there, you will try your best to preserve and work along with that because you are not doing ordinary surgery. When you are doing ordinary surgery, you have to decompensate so that you can mask the real severity so that you can plan to correct it. If it is masked, you cannot correct the entire thing, right? Clear? I'll give you 1 minute to go through these things and ask any question if you have before we proceed to the next topic. Just 1 minute for you to go through in your mind whether you follow what we have discussed yesterday and this revision. I understand what you do. Yes, you have to correct it. Yes. So the question is, sometimes you see that when you see the posterior curve of spleen, what is the curve of spleen? When you take a line from a buccal cusp of first or second molar and we draw that line until the canine and incisor, you see this natural curvature. So if I draw it out, how does it look? If this is your molar and this is your canine, it doesn't go like this. So premolars are slightly down. So there is a natural curve from molar till tip. So she's asking, sometimes we see that this curve of spleen is normal, but incisors are slightly extruded. So you have a flat curve of spleen, but you have this portion coming up. So it's like a roller coaster. So do we still need to settle down? Yes, you need to, because then your arches will not be level. Your arch leveling and curve of spleen live together. So curve of spleen is a posterior function and arch leveling is an anterior function. Then these two match it, because by definition the curve of spleen, see, these are technical terms. By definition, curve of spleen means you have to extend your circle from molar till canine till incisor and make a circle from TNJ. Remember that 7-inch or those things. But we don't go into this definition. So usually as a clinical clinician, we will see from molar to canine. But actually it encompasses incisors also. Remember, I made a circle from here, then I made a circle in this direction, and curve of Wilson, curve of Monson, and all these circles together become a sphere. So rather than to confuse you, I just chose to give a small definition. Once we have done this, everything clear so far? If you have doubts, you can ask me anytime, you can stop me anytime. It doesn't break the chain of thought for me. Thirdly, we studied the growth concept. We understand that growth doesn't happen same for everyone. So there is growth variability. Also, all your tissue doesn't grow at the same time. That means you have growth patterns. That means your maxilla will grow earlier and finish its growth earlier. Mandible will grow later and finish its growth later. Also, there is growth timing. That means not all the growth occurs uniformly throughout your life. There will be some spots where your growth will shoot up. There will be some spots where there will be less amount of growth. So these spots where the growth shoots up, we call it as growth spurts. And when we target our functional treatment or orthopedic treatment during these growth spurt, they respond well. That's why it's significant for us. How do we determine whether the patient is in growth spurt or not? Either by hand risk or CBMI. So CBMI, you understand that? We have C1, C2, C3, C4. C1 you cannot see because it doesn't have a body. So what you see in the X-ray is C2, C3, C4. If only one of the vertebrae has some concavity beneath it, that means your growth is about to start. This is the ideal time to target your functional appliances because by the time the patient will get used to the appliance, he will develop the compliance, you will be in a peak growth spurt. If you exactly give the peak spurt, maybe the patient is still not compliant, it will take some time and you will face some precious time. So the best time to enter is when the growth is about to start. So C2 has some concavity, C3, C4 is flat. But if you miss that, nothing to worry. C2, C3 have concavity, that means you are almost at the peak pubertal growth spurt. C3, C4 have some concavity and C2 have some deep concavity, that means you are at the peak pubertal growth spurt, almost decelerating now. And if all the four have deep concavities, that means growth is clear? This is an easy way. If you read, you will have body to height ratio and you will have concavity. When you match them, you will be more accurate. But as a clinician, one look at the set and you should be able to tell at least roughly what is the growth limiting or not. These are the questions we are looking for. So far clear? Let's go to the next topic, which is the diagnosis. Today we will have hands-on for cephalometrics and also we will have hands-on for diagnosis, chairside diagnosis. I have not discussed midline as a revision now because we will discuss it again during diagnosis and treatment planning. So far in examination, clinical examination and diagnosis, we just covered the most important feature. We left out case history, we left out the facial brachycephalic leptoprosotic because I told you that if the patient, rather than calculating the weight and height and then measuring, these measurements were given for a different population, all these things. So as a clinician, you have to see if your patient looks with a very long face and he has an open bite. That means if the patient's face is long but with occlusion and everything is okay, you don't need to worry, right? So the idea is, as a clinician, you have to look directly rather than depending on the numbers. So if you see a broad face, a wide face with a deep bite, you will understand that it's a brachycephalic patient. If the patient has a long face and they have open bite, it's a leptoprosotic patient. If you it's a tall patient and they have a long face, it's matching to their body, so you don't have to worry about that. And if they don't have a malocclusion or they don't have tummy smile, all those things, so it doesn't worry. The idea is, if you are confused whether this is leptoprosotic or brachycephalic or mesocephalic, that means most likely your patient is mesocephalic. A lepto and a brachy is very clearly visible. So far clear? Now we proceed with facial examination, which is your profile. You all know what is profile. Again with profile, if you are confused whether it's convex or concave, you can tell. If you're confused whether it's convex or straight, you can tell it's straight to mild convex profile. See here, we are not giving exam, nobody is judging you. You are the clinician, you need to treat your patient. If your patient is not concerned about the profile, and you are also not concerned about the profile, that means you are confused whether it's convex or straight. That means it's almost straight. That means you don't need to change it much, isn't it? Same way, I will not teach you like a professor in the university where you need to write the answer. I teach you as a clinician what decisions you need to make chairside, alright? So the teaching will be slightly different. So because in university you have A, B and C, but in clinics you have a range in between these also, which you need to identify and address. Understood? So we have concave, you understand what is a concave profile? There are 3 points on your face which you need to join. Imaginary you have to join. So you have to imagine in the patient, they look from the side and imagine. So these points will be the most prominent point of forehead. Let's not name these points. The most prominent part of the forehead, the deepest part of your, beneath your lip, around your lip and beneath the nose, and again the most prominent part of your chin. You should connect these points. Imagine whether these are joining as a straight line, or they are joining as a convex angle, or they are joining as a concave angle. We will do all these things chairside, alright? So learn the theory today, and then whatever is important chairside clinically, we will do a hands-on over it. So this is how a convex, concave and a straight profile look like. Remember, we are not targeting an exact straight line. Oh, my straight line is slightly curved, so this must be a convex patient. No, nothing like that. We have a range of normals, right? So if it's very clearly convex, you can say convex. When it's clearly concave, you can say concave. If you say by technical term, this also is a slightly convex profile, right? But no, it is normal. That means if you can say it's a straight profile, say straight profile. If you're confused, you can say straight to mild convex. Similarly, we need to know whether the patient is a skeletal class 1. Skeletal, we are not talking about dental. Angle is dental, which is based on polar relationship. I am talking about skeletal. That means your maxilla and mandible. So your patient is skeletal class 1, skeletal class 2, or skeletal class 3. How do you determine this information? Actually by cephalometry. You have to see your cephalometric numbers and then decide. But as a clinician, the first thing the patient will ask whether I require orthodontic treatment, do I need correction of my face or not? And you need to answer those questions. So technically you should have an idea. Alright, I am not commenting on cephalometry now because I will do the cephalometry and after that I will comment on that. So for now, clinically also we have to identify and also we have to identify cephalometrically. We will do both and after that decide what is more important for us. So clinically, how can you do that? You have multiple methods. What are those methods? We will discuss later. That means when you place your finger, if your finger is looking up or down, you can determine it's class 2 or class 3. We will do it chairside. I will explain you later. You can see here. Naturally, our chin is more prominent than our lips, isn't it? So when you keep your fingers like this, you have a small finger and you have a bigger finger. So when you keep like this, they should be straight because the back point, the front point, and the back point. Alright? If it is looking up, it means a class 3. If it's looking down, it means a class 2. You don't need all this to see whether the patient is a class 2 or a class 3, isn't it? Same again. If your patient's growth pattern, I will note down the things which we need to know to make our treatment plan, alright? Then we will see whether these things we can determine by self or without self or by both. Okay. So first thing you need to know is profile or skeletal malocclusion. Everybody can see. You don't need to understand my handwriting as long as you can understand what is the first word. So profile and skeletal malocclusion. Can you roughly gauge an idea without self clinically? We did that. We look at the profile and also we put our fingers onto the lips and chin and we try to find out whether it's looking, the finger is moving up or down. So class 1, class 2, class 3. Second thing we need to know is growth pattern. Whether the patient is an average growth pattern, whether the patient is a vertical growth pattern, or whether the patient is a horizontal growth pattern. What do you mean by growth pattern? The relationship of maxilla or mandible in terms of growth with respect to cranium. If your mandible is going downward rather than forward, you will have more tendency for long face and open bite. Whereas if your mandible is going more horizontally compared to vertical growth, you will have more tendency to have a wide and a short face and a deep bite. How does it make a difference in our treatment plan? What is the important, what is the relevance? We will cover them one by one. This is one of the most important features in planning your treatment. You will determine whether you require extraction or not, whether you require maximum anchorage or moderate anchorage. If you want to put a bite turbo, whether the bite turbo will be anterior or posterior. All these decisions will be based on your growth pattern. So please make sure that you understand growth pattern nicely. So to determine a growth pattern, you would have all studied, you will try to recall. There is a method that you put a scale on the FH plane clinically, and then you put another scale onto the chin, the lower corner of mandible, and when you try to join them, if they join in the occipital area, it's an average growth pattern. If it joins very far away from it, it's a horizontal growth pattern. And if it's joined too early, then it's a vertical growth pattern. Alright? This is a clinical way of doing it. High angle, low angle, it's synonymous to horizontal growth pattern and vertical growth pattern. Try to see how a vertical growth pattern and how a horizontal growth pattern compared to an average growth pattern patient looks like. So we are not obsessed that every patient button line should meet exactly at the occiput. If 1 millimeter ahead, it's vertical. If it's 1 millimeter behind, it's horizontal. No, it's roughly. So that means if your patient, if you're trying to imagine two lines, you have to imagine, because clinically you have to imagine. If this is matching here and this is coming here, and it's matching somewhere this region. It can be slightly ahead or slightly behind the occipital or the back of the head. It's still average. Because average is a range from here to here. It is not a point. So if your back of the head is here, and if your lines are matching somewhere here, it is still average. It should be like you are not able to match the line till the end, that means horizontal. If your line is matching somewhere here, only it's vertical. See? Is this clear? So can we make out this clinically? Clinically we can make this out, right? Whether the patient is an average growth pattern or horizontal growth pattern. So profile we can make out clinically. We have a good idea whether the patient is skeletal class 1, class 2, class 3, clinically we can make out. Also growth pattern we can make out clinically. Yes? Definitely we have cephalometric analysis, that is Tweed's triangle. You remember Tweed's triangle? We have Tweed's triangles, we have Steiner's analysis, which has a value GO, GN to SN. When you do this line, we will do all this. So these values will give you the growth pattern is horizontal, average or not. So if your FMA, Frankfurt's horizontal mandibular plane angle, is less than 25, it's a horizontal growth pattern. Remember? Slight amount of idea if you remember from the previous days. So the idea is we have cephalometric analysis to get this value. So this is how a mandible which is growing vertically, and this is how a mandible which is growing horizontally looks like. You can differentiate. So in your cephalometric analysis or in your cephalogram, or in your patient, if you see the patient's face is long and they have a good deep antegonial notch, these are the signs of a vertical growth pattern. That means mandible is not growing horizontally, it is growing more vertically, so the body is twisted around the coronoid process, so you have a deep antegonial notch. Similarly, horizontally growth pattern, you have mandible growing more horizontally, so the body is more or less flat or have a mild curvature. Which mandible looks more sturdy and stout? Horizontal or vertical? Horizontal. Compare them to a huge bodybuilder. Not huge, that is stout, sturdy. So a vertical growth pattern is thin and long. They don't have that strength, they don't have that stability. I'm just giving out a way to remember that. If you compare these two pictures and you see horizontal and vertical, these pictures coming in mind and you will be able to make this connection. So vertical growth pattern are thin and long, horizontal growth pattern are short and stout. That means they are sturdy. So the biting pattern is slightly, they have higher masticatory force. Because they have higher masticatory force, they are working out more, isn't it? So they are stronger, the bone are stronger. That means their anchorage value is slightly higher than the vertical growth pattern. So vertical growth pattern has lesser anchorage value compared to horizontal growth pattern. They have lesser masticatory force compared to horizontal growth pattern. It is now a counter question to you. Where do you think it would be easier for you to extrude the molars? Horizontal growth pattern or vertical growth pattern? Extrude the molars. Where would it be easier to extrude the molars? Horizontal growth pattern or vertical growth pattern? Vertical. Why not horizontal? Because once you extrude it, the masticatory force is going to push it back. Because it has higher masticatory forces, right? So if you have these concepts clear, when we plan our treatment, we plan our anchorage, you will have a good idea. So higher masticatory force, tougher bone, and higher anchorage value, all the three for horizontal growth. I'll repeat again because of the noise. I will repeat in terms of vertical growth pattern. Lesser masticatory force, weaker bone, and lesser anchorage value for vertical growth. Most of your cases will lie in average or average to horizontal or average to vertical. That means they are not outright vertical, they are not outright horizontal. If they are outright vertical and outright horizontal, you will see it very clearly. If you are confused, it is horizontal or average, you will say average to horizontal. Alright? Examination of nose, we will skip this. The important point is nasolabial angle. If your nasolabial angle, what is the nasolabial angle? You can see it clinically, also you can see it radiographically in cephalometric analysis. So the third point is nasolabial angle. These are all important features which will help us make decision whether you require extraction or not. That's why I am writing down on the board. Otherwise, the things which I am going to skip or not write here, that means they are important for you to know, but clinical application is not as important. Alright? So nasolabial angle is a line formed between the lower portion tangent to the lower area of the nose and tangent to the upper lip. What is the relevance? If it is too acute, it shows proclination of upper teeth. If it is too obtuse, it shows over retrocline teeth. Also the clinical relevance is if it is fallen back too much, if lip is fallen back and your nasolabial angle is too obtuse, the patient looks slightly older because the lip support is reduced. So if we over retract and we make this nasolabial angle too obtuse, that means we are going to make the patient look slightly older. So this decision is important. So normal nasolabial angle is slightly obtuse. That means it is around 95 to 100 and 205 degree, different population, different angle. But the idea is it is 90 to 100. Let us say 90 to 100. And if it increases too much, it is called obtuse. If it reduces too much, it is called acute. So the acute and obtuse term which we use actually is not like more than 90 is obtuse and less than 90 is acute, which we learn mathematically. We call it out obtuse and acute, so it leads to some confusion. Alright, so rather than that, we will report it as increased nasolabial angle or reduced nasolabial angle. It's okay? So if your nasolabial angle you feel it is increased compared to normal values, you will say increased nasolabial angle. If your nasolabial angle is reduced compared to normal value, you should say reduced nasolabial angle. How is it important, clinically relevant? We will discuss in detail. First, we need to identify. Later, its application we will discuss. So, how does this looks like in a clinical patient? This is a normal nasolabial angle. Although it is more than 90, we don't call it obtuse, isn't it? Because it's in a normal range. We call this obtuse when the nasolabial angle is increased drastically. Whereas when we call it, although this is around 90, but we still call it acute because this is less than the normal value. Alright. So rather than using obtuse and acute term, we will use increased or decreased nasolabial. So far clear? Now one more important feature of nose is, these are researches, you can read it later, it's a note, but we have to understand in terms of chin, nose and lips. You will have these researches, we will not read out, but the clinical significance is nose, lips and chin grow. You know that, right? So as a child is growing, all your nose, chin and lips are growing. What is the clinical significance? We will discuss once we complete all these. Okay? So for now, just I skip this slide. The slide mainly confirms that the nose is growing when the child is growing. Alright? There is a difference between nose growth, chin growth and lip growth for girls and boys, but that difference also we will discuss once we complete all the things. Are you all able to follow so far? Lips. Similarly, we have different type of lips. You would have studied in your videos. This is the most asked question. What is a competent lips? What's the incompetent lips? What is potentially competent lips? And it leads to confusion because the definition in itself is wrong. They tell you what is a potentially competent lip. In your books, this word is not used actually. In your books, the word is potentially incompetent. So you may get confused, alright? So I have changed the wording. So what is a competent lip? At rest, the patient lips are joining lightly or there is 1 millimeter or 2 millimeter of inside the display. It is called competent. That means patient doesn't have to make an effort to close the lips. If the patient is resting and more than 2 to 3 millimeter of incisor is seen, that means patient cannot close the lips naturally and they have to make an effort to do so. Now this can happen because of two reasons. Listen carefully. To close the lip, if your teeth is normal and then you are not able to close the lip, that means there is a problem with the lip. Or if your lips are normal but the teeth are too proclined, you cannot close the lip, that means there is a problem with the tooth. Clear? So if your lip has a problem, what can be the problem if lip is not able to join with each other? One of the lip is short. So if you have a short upper lip, you may have seen some patient, their mouth is constantly open, their lip is facing up like this. Yes? Can you see this? It is short upper lip. That means the length of the lip is not enough. So irrespective of the tooth position, irrespective of the tooth proclination, patient will not be able to maintain the lip seal. lip is not competent. Whereas lip is competent, but it is being interfered by the position or the inclination of the tooth. That means the patient has to make an effort to close it. And once you correct the inclination, the lip will be able to close nicely. That means it is competent, but it is potentially competent because it is being interfered as of now. Alright? In your books, you may find this written as potentially incompetent. So this leads to the confusion. So I've changed this, right? As a clinician, we don't need to go into definition. Idea is patient can close the lip easily, competent. Patient cannot close the lip irrespective of any position of the tooth because the lip has a problem, incompetent. If the lip is normal but patient cannot close because of the tooth, it is potentially competent. So far clear? Also you have one variety which is thick and fleshy everted lip, which we usually see in Afro-Americans, the thick fleshy type. How are these things relevant? Because once you retract your teeth, the lip is going to move back along with it, isn't it? So if your lip is very thin, it is going to fall back as your teeth is going to go back. They are going to follow the teeth very fast and easily. Whereas if you have a thick fleshy lip, that means they are muscular and thick and fleshy. That means they will not fall as easily as compared to a thin lip type. That means when you retract, the lip retraction will be not as much. So this decision has to be calculated when we are deciding whether we will make maximum anchorage or moderate anchorage or minimum anchorage. So another is lip type. So far clear? Everyone? Now what do you mean by lip strain? We will be using this terminology, lip strain, lip strain, lip strain. What do you mean by lip strain? So if you see this patient, she has short upper lip. That means her incisors, if you see, they are not so prominent. But still the patient is not able to get a good lip seal. It is because the upper lip is short. So when the patient has to work towards closing the lip, when they do that, they have to strain. And when they strain, the lip becomes tighter, the muscle activity increases in the chin, and the lip becomes thinner because it has to now contract. So this is how a strained lip look like, alright? So a short upper lip and a normal upper lip. Can you differentiate between the two? All we are looking here is how does different features look like so that if it comes in your patient, you are able to identify them. So now you may have this situation. What do you call this? Dummy smile. What would you, if you are not treating it and a specialist is treating that, what would you want a specialist to do for this case? What would be a tentative treatment plan to reduce this dummy smile? Put the entire maxilla up. Is it? No. What is the problem? Lip or the gums? Lip or the gums? So you have to identify the gummy smile is because of prognatic or vertically growing maxilla, or is it normal maxilla but the lip is short, that's why you are seeing more of gums. Understood? So a gummy smile can be because of multiple factors. Inflamed gums, gum comes down. Maxillary downward movement, that means it's a long face and maxilla is going more downwards. The vertical maxillary axis. Or everything is normal but the lip itself is short, so when the patient smiles, you see a lot of gums. So all the three will have different treatment plans. If it's inflamed gums and there is gingival inflammation and enlargement, you will just do gingivectomy and done. If it's vertically maxillary axis, you will have to impact the entire maxilla. If it's a short upper lip, you will not do these two things. You will suggest the patient, this I will try to reduce by making the incisor go slightly inside, but if I do too much, it is not good for you. So if you're not happy after that, you have to do some lip surgery to bring the lip. So all the three have different. So far clear? Everyone? 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 If I not hear enough voices, I'll continue like that. Everyone at the back is clear? Yes? So again, all these theoretical things you can read. This is another way of classifying lips, which is the relationship between upper and lower lip. Usually we have upper lip slightly ahead of lower lip, slightly. So we call it as a normal lip step. If this is increased, we call it as negative lip step. That means lower lip is far behind the upper lip. You see it in class 2. Whereas in class 3, you see a reverse relationship where the lower lip is forward and we call it as positive lip step. Alright? How is it clinically relevant? It's not so clinically relevant, it's just a feature you want to tell that the lower lip is ahead of upper lip. So you will not write it down there. The entire slide states that the lip grows as the patient grows. Now we will discuss it later in terms when we look at the growth and maturation of the face. Let us look at this picture. This is a pre-treatment picture of a growing patient, young patient. Chief complaint is malaligned teeth or she feels the teeth are slightly proclined. What would you do? Extraction or non-extraction? Extraction, how many for extraction? Raise your hands. It's okay if you make, see, if you make a mistake here, I can correct here. If you don't raise your hand, I will think you are able to follow everything and will keep processing. So, raise your hand, how many of you think it's a non-extraction case? How many for non-extraction? Very good. How many for extraction? Alright. So, it is very natural to have this confusion here because the patient has a lip strain. Also, when you see a gummy smile and patient chief complaint is proclined teeth. But when you see this, you have to identify 2 or 3 features. First thing, incisor inclination. If you see incisor inclination is near normal or slightly proclined, that is not severely proclined. And you already have spaces to correct that. Second, child is growing or a non-growing person. That means the patient is a growing or a non-growing patient. So she is a growing patient. Thirdly, we can see the lip is short. That means when the lip is short, you have this perceiving, the patient perceives that because they don't identify as a clinician, they don't identify the problem is with the lip or the nose or the chin. All they feel is the teeth is forward. So it's a relative feeling that the teeth is forward. Actually, teeth is not forward, it's the things around the teeth which is smaller. So just to give you an idea, if I am standing here, do you think I am short or tall? It's not easy to identify, but if a 7-foot person is standing beside me, I will look shorter. If a 5-foot person is standing beside me, I will look normal. That means we have this relative perceiving capacity. Because our teeth is surrounded by nose, chin and lip, individually looking only at the teeth, you cannot make this decision because it will have an effect on your all the 3 things, and all the 3 things will have an effect on your how the patient and other people perceive their teeth. This relationship we will establish over a period of time as we discuss more cases. That means, do you think the patient is growing, so the nose, chin and lip is going to grow in future? Yes? Do you think if the teeth are appearing to be prominent now, as the patient grows and the chin, nose and lip are going to grow around it, do you think this prominence will reduce automatically? That means the perception of proclined teeth is going to reduce as the nose is going to become prominent, as the lips is going to become prominent, and as the chin is going to become prominent. What do I mean by this? So let's say if the teeth and the nose are like this, and the teeth appears to be slightly more prominent. So you feel that the teeth is proclined. But as the patient is borderline case and you feel whether the teeth is proclined or not proclined. At least it's borderline, you are confused. Take your decision in terms of non-extraction, because the other things around it are going to grow and the patient is going to look less prominent teeth compared to what they are looking now. Is this point clear? In growing patient, don't make extraction decision easily. This is what I want to write. Don't write down that it's always non-extraction. Make down a note that don't decide for extraction easily. That means if all the features are pointing towards extraction, good. You need to extract, you extract in a growing patient, no problem. But don't make this decision very easily. That means it's borderline case, I can't decide, I will extract. Don't do that. Alright? So let's see what we did in this patient. We closed all the spaces. Look at the teeth inclination, they look pretty normal now. But if you look at the patient profile, the lip strain is not so much now. But the patient is still not able to close the lips. Why is that? Because it's the problem with the lip, not with the tooth. So the note which I have written is good occlusion, canine and molar. Patient's mother felt the teeth are still proclined. So we have to educate them. It is not the teeth proclined, it's you feel because you are not able to close the lips and you can see the teeth. So we have done here, we have taken all the records, we have examined, discussed with mother, mild proclined upper lower but not so severe, short upper lip, and she is a 13-year-old female. And there is still lip, chin and nose growth remaining. That means extractions are not advisable. Patient mother also agreed and decided to finish non-extraction to anticipate the facial growth and lip to compensate for this problems. Is this point clear? That means sometimes when you are finishing the treatment, you may not be happy, but as a clinician, you know, especially in a growing patient, you are looking forward. You know that this patient is going to grow in the next 1 or 2 years, and then the face is going to change, and this is the face she is going to carry throughout her life. So if you extract as a 13-year-old for her, she will look good now, but throughout her life she will look sunken face. Is this point clear? So your decision making in a growing patient is slightly more complicated compared to an adult patient. Is this point clear? So be very careful. Again, chin examination, normal chin, prominent chin and recessive chin. We are not going to use this terminology as positive negative. We are going to use normal, prominent and recessive. Now we studied lip, we studied chin and we studied nose, and these are the features which are guarding your teeth. All the three features are around your teeth. So the relationship of these three features with each other and the relationship of these three features with your teeth is going to affect the perception whether the teeth is proclined or not. Perception, the word is perception. Because proclination is partly functional and partly aesthetic problem. If your function is good and the aesthetics part, that means even though your teeth is slightly proclined but nobody can perceive it, it's not a problem, isn't it? So this relationship of lip, chin and nose, we call something called as E-line. We will discuss it later when it comes, and also we will do it clinically. It is clinically very relevant. E-line, lip, nose, chin relationship. So far clear? So this is how a recessive chin looks like, and this recessive chin, if it's combined with a proclined incisor, you have a lip trap, and because of lip trap, you have this puckering of chin or a mentalis activity, also known as golf ball appearance. This is how a vertically growing patient looks like with a recessive chin. Can you see? One of the craziest patients I treated. He didn't give permission for showing this way, so I have to remove him notes, but still showing it. Okay, we will discuss this case later. mid-face deficiency, as we discussed yesterday, it's seen in class 3. What do you mean by mid-face? This prominent, the cheekbone is not so prominent in such faces, and the face appears to be sunken here. It is more commonly seen in class 3, and it's very much visible on a 3-4 picture. Yesterday we took a 3-4 picture, right? Extraoral 45-degree picture. You can see this. The relevance of this point is not so much. When we plan for orthodontic surgery, they try to enhance this bone, so you are not going to do it. You will not spend a lot of time. Now that we are here at this point, we studied the lips, we understood the maturation of lips. I will, in short, there is detailed studies and supporting articles inside your notes, but we are going to study in short. So lip is going to grow longer, and initially it is going to get thicker and plumper. So when a child is 9, 10, 11, 12, 13, 14, 15, 16, till that time lip is going to grow longer and it is going to go thicker. After that, after 16, 17, 18, so every patient has different age, but the idea is as they are going to go into adulthood, the lip thickness is going to get reduced, they are going to get thinner comparatively. That's why you have fillers as you grow old. Alright? And the lip length becomes stable. So what did we study? The child grows, the lip is going to grow first until 16, 17, 18 years, and after that it is going to stop. So if your lip is slightly short at a 10-year-old boy, that means it may not be very short, that means the growth is still remaining, and if you prescribe lip exercises, it is going to grow normal. Similarly, nose. The nose is going to grow longer as the patient is growing, that is 16, 17, 18. After that, nose growth also stops. Similarly, chin is going to grow as the patient is growing from 10, 11, 12, 13, 14. So if we combine all this data, we understand that everything around the teeth is going to grow from 10 years to 16 years, and after that it is going to stop. So if you have a patient within that range, and if it's a borderline patient where you think the lips are slightly prominent, teeth are slightly prominent, you have to understand that it may be because the growth is still remaining, and once all these three things are going to grow, this prominence is going to reduce. So far clear? So this is the So what she is asking, what is the lip exercise and until what age does it help? It will only help until there is a growth potential. And we know that the lip is going to grow till 16, 17, 18, and it can be different for different person. So let us say until 18 we will keep trying. Maybe for that person 14 lips growth is over. So, but we will still try. We want to make all our efforts. First thing. So until what age you can give the lip exercises? You can give until 14, 15, 16, 17, 18. As long as you want to try, it is up to you. But 14 to 16 is the age where lip stops to grow. Alright. Secondly, what are lip exercises? Nothing. It's a simple exercise that you can ask the patient to hold a piece of paper in the lips. So to maintain the lip seal, you can ask them. Button joined with the rope, so there are button at two ends. So they put the button in between the lips, and then they hold from the other side and they pull it. So they are trying to hold the button with the lips. So it's again a lip exercises. Once you Google lip exercises, you will find them. There are appliances to make lip exercises. One of the appliances you would have studied. Oral screen you have studied. Oral screen. Tilo. That Google oral screen. Pedodontics oral screen. Pedodontics oral screen with HOTZ modification. HOTZ. HOTZ. Pedodontic oral screen HOTZ modification. Images. You are all able to see it. So it has a screen which is in between your teeth and lips, and there is a small hook or a ring attached to it. So patient can close the lip, put the screen in the mouth, close the lips, and using that screen they are trying to pull it, and with the lips they are trying to hold it. So you are trying to exercise your lips. Some people do a simple exercise, they just put water in their mouth and keep rinsing for half an hour. Again, they are doing the same thing. So the idea is as long as you can increase the lip function. So the relevance is clear or not? Yes? If we combine a gist of all this, we will say in short, in growing patient, because the other features are still growing, if it's a borderline case, don't make an extraction decision so soon. Because the patient is going to grow and the looks are going to change. So later on you can read these clinical researches. Also, you have to remember that growth occurs faster and earlier in girls. So if your lip is going to grow till 16 and 17 in boy, if the nose is going to grow till 16 and 17 in a boy, it will be slightly faster and earlier in girls. So the limit of nose, chin and lip growth in a girl may be 14 or 15 and in boy it can be 17. Clear? Now when we discuss this in growing patient. Also maturation happens, right? As we grow old, we are not growing, but the support of the lips, the skin, the soft tissue, they are sagging, isn't it? So we are going to mature also. Growth and maturity is a different thing. Growth is in size and maturity is in quality. Yes? So as we grow old, we are going to mature and look different. The support is going to reduce. That means lip is going to have more sagginess. The chin is going to have more sagginess. So what happens usually when you have, especially in my practice, I have an adult patient pool which is higher than the growing patient. Here in Malaysia, the education and awareness is more. So you have very good patients of 15 years, 17 years, 20 years, 22 years. They have good complement of teeth, everything is present and it's not so difficult to plan a treatment for them. I have adult patients who start their treatment usually when they are 30s and their oral hygiene and awareness is not so good, so they have at least 1 or 2 teeth missing. So my patient pool is slightly more complicated, and especially females, they start to get more conscious about their looks when they are 30 and they come to us and we are doing the treatment. During that time they can get pregnant, so the facial features, body type, everything is going to change and they are going to blame you for that. Alright, so one of the example is, so the idea is you have to be very careful, you have to be very aware of it. Let us see this example. Now this patient came to me during her treatment, and because of her pregnancy the treatment increased to 3 years and she was missing MIA for at least 1 year in UK. And when she returned, she said, "Doctor, everything is okay, but after your treatment I feel my teeth, my lips is slightly gone back and I look older." Does she look older? Yes. 3 years, mid-age female, got pregnant. She is going to put on weight. She is going to have facial and body changes. Luckily, I had not extracted in this case. This is a non-extraction case. And crowding. That means her lip prominence actually increased. If you see from here to here, lip looks more prominent slightly because the teeth proclined because it was a non-extraction case. But she still perceives it as the lip has gone back because she has put on some weight, the lips have become slightly more loose and she has put on some weight on the cheeks. So she has perceived that her lips doesn't have support, and also she is looking at her friends, they are getting fillers, botox, all these things. So the idea is sometimes you will be blamed for things you have not done, and if you are aware of that and you keep taking your records, you can justify it. If you don't take your records, suddenly they will start blaming. Alright? If they can blame the husband, it's okay, otherwise extra over done. All these features, is there anything you want me to repeat? Profile, we can measure it clinically, we we can see it clinically and measure it cephalometrically. Growth pattern. Again, we can make that out whether it's an average, horizontal or vertical growth pattern clinically, also cephalometrically, which we can learn. You have values attached to cephalometrics and you have an idea attached to your clinical skills. Again, nasolabial angle, you can see clinically or cephalometrically. Lip type, you can see both cephalometrically and clinically. E-line, you can see clinically and cephalometrically. So far, whatever was important for us to make a decision, we can do it either by clinically or cephalometrically, and best is if you do both. Clear? Now coming on to the intraoral examination. Before we move into it, you can take a 5 minutes break or 10 minutes break to refill your coffees, relax yourself before we go into the next one. If you have any question, you can post a slide or you can ask.